Dr. Ahsina Jahan
So,
Lopa from
should I?
Samorita Medical College and Hospital. She is the critical care head there, and I can't find any good name who can explain this better than this. Dr. Lopa, please.
Okay, thank you, Dr. Ranaji. So let me share my screen. The topic is today is the CRRT, who is in charge. So, and there is an article here. There is the who should manage CRRT in the ICU. So the intensivist viewpoint. Back in the year in 1997, the renowned intensivist Dr. Rinaldo Bellomo published this article where it's highlighted this issue of who should manage CRRT in ICU. So the arrival of continuous renal replacement therapy has given the intensivist and the intensive care nurse the opportunity to treat acute renal failure independently by giving them the necessary technology and taking CRRT away from absolute nephrological control. This structural shift has created a controversy between those countries where control of CRRT has completely shifted to the intensivist and those countries where nephrologist input is still dominant. And the argument is in favor of intensivist-driven CRRT rests upon several observations, including the fact that therapy is continuous. So as is the presence of the intensivist in the intensive care unit, so the critically ill patients require rapid changes in treatment that are the best directed by physicians who are at the bedside all the time. So CRRT must be seen within the totality of patient care, and the intensivist can see the larger picture more accurately. So intensivists are successfully performing more and more procedures that were previously seen as part of other specialties. And last but not least, closed models of ICU care appear to work best. So Australian intensivists have taken up CRRT from the start and now confirm the effectiveness of such an approach. So it should be done must be by the intensivist. So it was actually in 1997. So in the but in 2013 there is an article published where we can see in the conclusion that where is the conclusion is it shows that in Europe CRRT is the preferred technique and mostly operated by the intensivist. So this is the study done in the Malaysia in ICU. In the result, we can see the survey was done that were within 19 physicians, and the dealing with the RRT, out of them, 16 were intensivists, 2 were anesthesiologists, and 1 is the nephrologist. So, but in the Far East, RRT in ICU mostly covered by intensivists. And it is an important thing to mention here that recently ICCM expert panel is working on a practice recommended for RRT in adult ICU, in which myself is also happy to be a part of it. What we have understood is that intensivists should do the CRRT. So here we have actually to recognize the need of RRT and should be able to start this therapy at the appropriate time without causing the harm. So actually, in previous lectures also we have all have covered that what is the RRT in ICU. That's the CRRT is the continuous process, and the SLED is prolonged duration, and it is done in daily basis, and also the IHD is the intermittent. So within the model, it is logical that the intensivists take initiative for the medical management of AKI, while critical care nurses or technicians perform CRRT troubleshooting on a minute-to-minute basis within the ICU. And renal replacement therapy, especially CRRT for AKI patients in ICU, are considered part of core intensive care training. So now there is a question. So problem is not the problem actually. So monitoring with the nephrologist, what happens? There's the availability around the clock. What we actually face in the daily basis in our ICU also. There is the their availability and also the monitoring and the troubleshooting of during the process, and it's the difference in approach. What we feel that when a patient is admitted in our ICU and the patient is very critical, so how we counsel the patient, what will happen to the patient, so what is the outcome, and there are sometimes the multi-organ involvement of the patient. So this approach is also very important for us because the patient is admitted in ICU. So there is sometime the I often there has some limited interest also. And what is the situation in this incredible world? That is the doctor, what is saying to a patient that your father has had a cardiac arrest, so we are trying to revive him. And the patient's answer is, did you call a cardiologist? So what happens? So dialysis, kidneys, and the nephrologist. So what is our actual situation is here, that what should we do? So this is a very incredible situation when a doctor says to the patient party and the party is not convinced, so you have to be wilder or scratch your head. So here we have in the ICCM recommendation, Indian Society of Critical Care Medicine, that is the, you have to evaluate the need of RRT for AKI. And yes, there we actually, there is something we can say that the shared decision, it must help the patient party actually, because the family interest and they want to know, is there any nephrologist was available during the CRRT or SLED or ISD. So we have to, sometime we need this thing that yes, nephrologist is also in loop. So there should be like intensivist, nephrologist, always there. We can keep them in a loop. And then we can start the CRRT and SLED and the shared decision for limiting or holding or stopping the therapy. And the pragmatic approach, what I can say that the intensivist and nephrologist, I'm not saying that yes, no, we don't need nephrologist anytime, intensivist can do. Yes, we can do. And because round the clock, we have to see the patient and we have to take care of that patient. And whenever the troubleshoots happen in our ICU, so we have to deal with that patient actually. So now we can say in my country, I can also, I can share this, that in my ICU also, we take the decision about when to start a CRRT or when to start a hemodialysis. So at that time, patient party, they knows the patient is critical, so consent and other is given to us. And yes, if it's possible in the morning clock, we call the nephrologist and nephrologist come also. We just show the patient party, yes, nephrologist is there, but all things is done by the intensivist. So this is the reality in a hospital like Samorita Medical College also. It's a corporate hospital. I can say it's a medium category corporate hospital, but we individually, we do the procedures actually in our ICU. So the key points is here, the critically ill patients in ICU may require RRT, either emergent or as planned or routine. Intensivists with adequate training and experience in RRT can initiate, monitor, or supervise the process. And the multidisciplinary holistic approach should be promoted as and when required. So I think I tried to complete it in a very summarized way. So thank you very much.
Very nicely described, Dr. Lopa. I think you left no stones unturned in making the process, especially the picture that you have chosen for the intensivist and the nephrologist is quite interesting, showing a quite young person as an intensivist. Well, I always feel that the awareness, the eagerness, the good teamwork and coordination, the availability of the consumables, and a very receptive and encouraging administration and a standard ICU care is more important when you start a CRRT program, because if your administration is not encouraging, not receptive, If you can't make them understand, yes, it's the process might be costly, it might be saving patients. And yes, nephrologists may be kept in the loop, but CRRT, as it is already in the basic training of intensive care, can easily be handled by intensivists. There is no doubt about it. Regarding IHT, there is no doubt that it should be done by the nephrologist. And as SLED, a hybrid process, it's a hybrid one, both intensivists and nephrologists. That what is my opinion. Thank you so much. I think the whole this is a mega program today. And Dr. Vivek, Dr. Vinay, Dr. Sharmili, Dr. Lopa, Dr. Abhishek, everybody contributed equally and fantastic presentations. It's not so easy for for the first one to. I don't know how much we have explained it to others, how much people have. They might have. Many of you must be doing it also, and whether you have been helpful, that this is helpful or not, time will tell.